So just stop for a second. You've had 2 or 3 goes at that. Why do you think you haven't succeeded yet?
Because there are a couple of bends coming after each other.
That's life in the colon. That's not what the question I asked.
Probably also because I'm not going slowly enough.
So I need to do 2 things. I'm observing 2 things. You need to go slowly. And the second thing you need to do is you need to decide whether you want to move the tip or you want to torque the instrument. And I want you to get into the concept that if you're going to torque, you're going to move it a long way. And if you're going to move a tip, you're going to move it a small way. Okay? So straight ahead. And can you just deflate the colon, because the less distended it is, the shorter it is, and the less acute the bends are. So just stop there. Just suck the gas out. Do nothing but suck the gas out. And as the colon moves, just guide the tip forward. Suck, 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 suck. Keep sucking, keep sucking, keep sucking. Stop. And then just put a little bit of air in to distend it. Fine. Stop. Look at the image. Look at the blue screen. Tell me what you're seeing.
There is a buckle forming.
There is indeed a buckle forming. Where do you think that buckle will be anatomically?
So in the transverse colon.
It is in the transverse colon. So you've gone past the apex of the transverse colon. So rather, if you push in, we can try that because the patient's under sedation. If you push in, what will happen is the transverse colon will dip down and ultimately you will start to go backwards, I think. Okay, do you want to try?
Yeah.
Stop. Can you see what's happening?
Yeah, it's
going up and the angle's getting more acute. So that's not the right solution. So the right solution is
coming back.
Anything else you could do?
Or change the position of the patients.
And if you were to change the position, what position would be optimal?
Probably the supine position.
Probably or definitely?
I think so.
I think not.
Okay.
The optimal position here will be the left lateral because it will keep the air up and it will open up the angle and it will bring the hepatic flexure down towards you. But the downside to moving the patient in the left lateral is what?
What it does?
Yeah, what's the downside? What's the negative of moving the patient in the left lateral?
Well, then the sigmoid is falling down, and also the buckle that we see is going down with gravity.
Not quite. Try again. Where's gravity going to be acting on the colon with the patient in the left lateral?
Sorry?
Where will gravity be acting on the colon with the patient in the left lateral? Where will be gravity having its greatest effect in the colon with the patient in the left lateral?
In the descending colon?
It's in the transverse colon, and it will pull the transverse colon down and away from the hepatic flexure. And that action effectively makes the angle at the hepatic flexure less acute, but it also drags the transverse colon away from the hepatic flexure. Do you see that? Makes it longer. So in my personal practice, although that is a reasonable thing to do, I would prefer to do hand pressure. So I'm going to ask you to ask whoever's assisting you to put their hand in the abdomen. If you've got a marker, great. And if you haven't, I would predict it's just to the left of the midline. And the action is you want to pull the colon up and out towards the right shoulder blade. And look at the blue imager and see if the colon moves when she does that or he does that.
Yeah. Okay.
This is easiest done in the supine position, which is in between the two we talked about. So bring the marker on the blue across to the knuckle or the buckle. So a good way to use the marker is use the pen to get it just down a little bit. Yeah, perfect there. And then pull it up. Okay. And what I would like you to do is just to aspirate, suck, 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 and insert very slowly with a little bit of anti-clockwise torque. Very slowly. Don't worry that you can't see. Just keep going forward very slowly. Very slowly. Suck, suck, suck. Drag yourself forward. Suck, suck, suck. Suck, suck, suck. You just need to get beyond that fold. Just try to go a little bit further. So just stop. Can you see that your dip has got larger, which means the hand pressure isn't working? So you need to bring it, you allow the loop to come up. So you withdraw the instrument and then you ask the nurse to reposition her hand. Great. Try again. Pressure again. And then nice and slow. Slow insertion. Suck, suck, suck. And then tip deflect. Tip deflect down, 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 down. Anti-clockwise torque. Anti-clockwise torque. Good. Tip deflect down. Good. Okay, bring the tip up now. Bring the tip up. Go from down to up. Good. Suck, suck, suck. So just pause for a second. We're just doing things a little bit too quickly. You need to know which direction you need to turn. You've gone past it. Stop there. Just insert beyond that fold. Bit of clockwise torque and tip up. Stop. Put a little bit of air in. Gently insert, gently insert, gently insert, gently insert. Ta-da. You can let the nurse, tell the nurse to take the pressure off. So, tell me what you did and why it worked.
I'm going too fast. So going much slower helps.
Yes.
Also keep the lumen just in front of you to know where you should go instead of going blindly. And then with the right pressure, indeed, you see that you're advancing.
Very good. So we have a problem. We looked at what the solution was. We tried what we thought was the right solution and it didn't work. So we simply pulled back and then reapplied the pressure in a different way and then it worked. So can you see how we have a logical approach to getting around the flexure? So you have a different problem now.
Yeah.
Which is? What are you trying to do now?
I'm just looking around to have a bigger overview.
Okay, so I'm going to say, what do you think my instructions are normally to the nurse if I'm in my own unit when I reach the cecal pole like this? What instructions do I give to my nurse? Not now for you here, but what would be the optimal things to do when you reach this point? We're trying to maximize our views here. So what things can we do to maximize our view?
Change position.
To which position?
To the left lateral.
Are they already in the left lateral?
Yeah, and then I would switch to the right. Right.
So we want to be in the right lateral, and I ask for some medication. Which medication do I ask for?
You can give Buscopan to relax the colon.
Okay, so there's really no downside unless there's a cardiac contraindication to giving Buscopan. So I ask them to move them onto patient onto right, and I give some Buscopan, and then I add a little bit of air, and I use the water pump to flush the cecal pole. And as the patient rolls onto the right-hand side, the water in the cecal pole then drains into the ascending colon, and you have a beautifully clean cecum. Mm-hmm. Now, I'm going to defer to David, who's in the room. The patient is under a GA and is in the left lateral, David. And if you don't want to move the patient, that's fine. It's a compromise. If you can move the patient, if there's one position for sedated patients, I would say supine is better than left lateral.
So, John, do you think we should move the patient to the supine?
Do you mind?
Yeah.
It would be a compromise, but it'd be better than the left lateral, I think.
We will move the patient to the supine.
You're doing really well.
Dan is dat been erover zetten.
Naar rug of direct rechts?
Direct rechts.
But you need to do it slowly in stages. So nice and slow. I'm not convinced the pressure's in the right place, but we can try. You're forming a loop. So just humor me and get someone to reposition the imager so you've got a proper image on the imager. And whilst they're doing that, talk to me about what you're going to do and the things you're going to look for and feel.
Nee.
So stop there. Just stop.
Yeah.
Okay, so you're now at the point of no return. And the reason I've stopped you is because you haven't answered my last question, which tells me you're focusing very high. Your focus level is very high on the screen. So just tell me what you're looking for as you advance the scope now. What things are you trying to be aware of?
Just to know where we should go in the end.
So one is where you are in terms of the luminal view to make sure you're orientated and know where the lumen is going to be. That's the first thing. And what about your right hand?
My right hand will give some torque.
Yeah, you might use your right hand for a bit of torque.
Yeah, and also to draw back.
Correct. So I want you to push in, and if you push in and the tip isn't moving forward very quickly, you need to make sure you're not reforming the loop.
Yeah.
And therefore you need to help your nurse to tell her to make sure she's in the right position. And if you start pushing in and it's forming a loop, you're never going to get through. You have to stop, pull back and start again, just like we did, when we were successful the second time. So let's do everything nice and slowly and controlled. Let's be happy that the nurse has got her hand in the right place. Let's push very slowly and predominantly use tips there. You might here want to put a little bit of water in rather than air, so it doesn't distend the ascending colon and make the angulation more tight. So try and use water to distend, and now use your tip. Tip up, good. Water to clear that, and wait for the spasm to diffuse. Do you know where the lumen is now?
In front of us.
And then what direction? The reason I ask you the question is, if you're going to start applying some torque, which torque are you going to use?
Clockwise?
No. Do you know why it's not clockwise? It's anti-clockwise to bring the splenic flexure forward. And if you need to go 90 degrees of clockwise torque, you should probably be doing 270 of anti-clockwise torque. And that involves quite a lot of dexterity with your wheels.
Yeah.
Just try and slowly rotate the scope anti-clockwise for me. Yeah. Okay. Now start to advance the scope slowly. Slowly advance. Slowly advance. Anti-clockwise. 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 Great. Get up to this fold, which is now sitting at 6 o'clock. Yeah. Get the tip beyond the fold. Okay. And if you go and add some more anti-clockwise torque, you can then bring the tip up and to the left. Nearly. You're straight. You're not reforming the little knuckle. So advance a little bit further, get you a bit more stability. You're turning too early, so go beyond the fold first. I can palpate the frustration from here. Good. Tip right, tip right, tip right. Good. Tip down.
It's really a very strange movement I have to do with the torque.
John, would you like
That's
us to move
another
the patient back on the left
No,
side?
no, no, no. She'll do this. She'll do this fine, David.
Okay, well then we've got 4 minutes
Just
before we're done with this
insert
technique.
to the where the lumen is. You've only got to insert another 2-3 millimeters. Go on. It should go round, David, because it's straight. Just use the wheels, Sarah. Use the wheels. Good. That's it. Stay there. Slow movements. Slow movements. Gently insert. Gently insert. Bring the tip back down. Fantastic. Okay. Pause for a moment. And if you're going to move the wheels, move them a small amount so you can find where you want to be. You're underwater because you're sitting in something called a paracolic gutter, which is sitting just underneath the ribs at the hepatic flexure. So you're about to go around the corner. The lumen's up at about 1 o'clock. So just rotate a little bit clockwise maybe and bring the tip up. Good. Come back off the mucosa so you can see. Good. Good. Keep going. Good. Whoa, genius.
Look at that.
Suck, 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 suck. Great. David, I'd suggest you got enough learning out of this.
Yeah, I totally agree.
So Sarah, what did you learn from that, or what did you find difficult? And maybe a different question is what did you do different to what you normally do? And did you find that helpful or not? They're the things that, if you can just get your head around that, just give yourself a minute and think about it.
Meantime, we can review the case and fast.
So yeah, what I learned here, but it's something that I already know, but easily forget is that I always go quite fast, and that it's better to use small movements.
Yeah.
So that's definitely, I think, the main point I should keep in mind when I do a colonoscopy. Then something that I'm quite aware of is to use the suction when needed. But what I found quite difficult in this case was the point where when I went to the cecum and then with changing the position of the patient falling back, then I was really struggling to get the scope in the right position and do the anti-clockwise torque. That was kind of an unnatural movement for me, something that I would definitely have done myself. So that was quite difficult.
So can I firstly apologize because you'd put the patient in the right lateral, and then I didn't realize you'd done that and started moving the patient, and then I think that's when you lost the scope. So I have to take partial responsibility for that, undoubtedly.
Okay.
But equally, it's a great learning message. Having spent some time getting round, particularly if it's a difficult case, we don't want to lose position. So when we're moving the patient, or if you're moving the patient, the endoscopist's responsibility really is just to hold the instrument and look at the screen, and everyone else should really support you in moving the patient if that's required. And it's good on you, and it's probably a reflection of your personality that you want to help out. But realistically, your responsibility is to take care of the scope, because it then took us another, 7, 8, 9 minutes to get back into the cecum when we'd already been there.
Yeah, definitely.
Okay, so the technical challenge in what was left of the colonoscopy was negotiation of the hepatic flexure. Yes?
Mm-hmm.
So just tell me in your mind how you solved that problem, how you think you solved that problem ultimately.
So ultimately, I think what was definitely the right thing to do is pull back to the point where you just remove the buccal and just stay there and try to keep the position stable. And then with the right external pressure by the nurse, because that was, I think, also a bit of the problem, that the external pressure was not immediately right. And then I think I should have maybe checked it myself or so, instead of trying to push indeed further while it was not optimal.
It's maybe interesting for those watching, both of you, to indicate what was wrong with the pressure that the nurse was giving? Because you can precisely see what she's doing here as you're pushing in. So what is the problem?
That the pressure was not at the right point.
Or should it be? So right now
or
it's
to the
here.
right.
Here.
Yeah.
And then?
She looks like she's pushing up into the center of the abdomen, doesn't she? And she needs to be pushing up to probably towards the right shoulder.
Mm-hmm.
But the key thing is, Sarah, for the pressure to work, your scope has to be pulled back far enough so there's really little angulation at the tip. And it also means that the mesentery and the colon are not stretched very much, and therefore the pressure can actually then move the colon. If everything is already stretched, there's very little scope to move it because it's relatively fixed. So it has to be nice and soft and malleable and amenable to pressure. So you have to pull everything back till it's very straight. Yeah. And I think in your point, and I appreciate your problem in that you are struggling to apply anti-clockwise torque. Your tendency was as you're moving the scope, you were tending to lose ground, and therefore you would push in, to try and keep the ground. And as you did that, you reformed the loop at the tip, or you're beginning to start a loop at the tip, and you never quite fully pulled it out. And you have to get in your head, the mental concept is it requires quite a bit of anti-clockwise torque to bring that splenic fletcher completely forward, and then the withdrawal of the instrument straightens it up. And you have to be really brave. And I'm going to make a small suggestion that is when you're doing that, if you're struggling with the tip control to get it to where you want it to be, it's usually a problem with your left hand.